Okay, welcome everyone to updates from ASCO. During this seminar, all participants will be in a listen-only mode, and there will be a question and answer session at the end of the presentation using questions submitted through the Q&A feature. Please remember that information provided in this web seminar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild. I am the Executive Director of the LifeRaft Group, and I would like to introduce our presenter for today. Dr. Herbert Loong holds conjoint appointments of Clinical Associate Professor in the Department of Clinical Oncology and Deputy Medical Director of the Phase 1 Clinical Trial Center of the Chinese University of Hong Kong. He is also the current and founding convener of the Prince of Wales Hospital Adult Sarcoma Multidisciplinary Team, and he obtained his medical degree with a distinction in surgery from the University of Hong Kong in 2003. He's a recipient of the European Cancer Congress Fellowship Grant in 2013, the ASCO Annual Meeting Merit Award in 2014, and the Hong Kong College of Physicians Young Investigators Award in 2014. And he has been a longtime friend of the LifeRaft Group and has been so gracious to share updates from these scientific medical conferences for us in a way that is understandable to the patient community. So thank you very much for doing this again. And I would like to hand it off to you to get started.
Thanks, Sarah, and it's always a pleasure to be able to speak to the LifeRaft Group community. I'm Dr. Herbert Loong. I'm based in Hong Kong, so good morning, good evening, good afternoon, wherever you are, and it's a real pleasure for me to be able to give you some updates on GIST abstracts that were presented at ASCO just a couple of weeks ago in Chicago. I'm going to try to share my screen first. So in the next half an hour or so, I'll just go through some of the abstracts that were particularly interesting, at least from my point of view, in terms of in the GIST space that was presented at ASCO. And these are my disclosures. And a bit of a disclaimer first, we'll be using some of the slides that were presented at ASCO, and certainly the copyright of these slides belong to the original authors. And I'm using this by courtesy, mainly because of the fact this is an academic as well as patients' educational event. The choice of the abstracts that I would be discussing are really based on my own assessment and its impact to the GIST community, and it doesn't necessarily reflect the views of ASCO. And to begin with, maybe just take a step back and just to remind ourselves where we are in terms of the treatment of GIST, and specifically probably in patients with advanced or metastatic disease. We know that we have good targeted therapies available, and certainly, we now have not only just one line of treatment with imatinib, but we have second line, third line, and fourth line, and there are new drugs being developed in this therapeutic space as well. What we've also realized, though, is at least in the last decade or so, our treatment approach has really been relatively pragmatic, where we are actually looking at essentially treating patients with frontline treatment with imatinib, and then when they get to a state of, say, disease progression, we might switch to second line and third line and fourth line, a relatively pragmatic manner without really looking into different molecular subtypes that may happen, especially when you have, say, treatment resistance after initial treatment with a targeted therapy. Having said that, we of course know that our drugs actually target different molecular alterations differently. The graph here on the right-hand side shows the different types of the targeted therapies, and you can see that inherently, in actual fact, some of the targeted therapies work better on some of the mutations. And in the older days, when there were not many choices available, again, we would take a very pragmatic approach, just like the slide on the left. But now, given the fact that we have this molecular profiling knowledge, we know that our drugs actually behave differently in different situations. There is now a consideration of possibly altering this relatively pragmatic approach and make it more dynamic, really looking at the molecular changes that occurs after initial treatment and then choosing the right drug in the right position or space. And this has been evidenced in prior clinical trials, really indicating the fact that the molecular testing, especially upon a disease progression, is important because we are then able to hopefully be able to channel the more appropriate drug treatment for our patients. Now, I've selected actually 4 abstracts that were presented at ASCO this year. One of them was actually an oral presentation. The other 3 are actually poster presentations, and I think it's very important for us to not only remember the oral presentations because they get a lot of focus and a lot of attention, but the poster presentations often provides a wealth of knowledge and a lot of discussion, which actually stimulates further collaborations between collaborators and investigators. But let me go through the oral abstract first, and this was actually an abstract presented by Dr. Ping Chi on behalf of her colleagues on a study, on a phase 1 study of a broad-spectrum KIT inhibitor known as NB003. And this is actually an update of the phase 1 study. In actual fact, their team presented data at the last ASCO in 2024 of the same trial, where it was a little earlier in the trial progress. And at this moment in time, they have a larger number of patients recruited and are able to present some more updated results. So going back to the presentation itself, again, this is a presentation on the broad-spectrum KIT inhibitor known as NB003, or also known as ubavitinib. And Dr. Ping Chi was, of course, presenting this on behalf of an international group of colleagues with investigators in the United States, in the United Kingdom, in China, as well as other regions, including Korea. So again, a bit of background, which actually also serves to be quite useful for our presentation, really knowing the fact that with GIST, about 80 to 90% of these GISTs are actually driven by molecular alterations, specifically with KIT or PDGFR alpha. And in terms of the approved tyrosine kinase inhibitors, such as sunitinib or regorafenib or ripretinib in the subsequent lines, unfortunately, based on our prior treatment experiences, their amount of duration of treatment is actually relatively short. And the other issue is with the second, third, fourth generation TKIs, they all have specific targets where they are not necessarily able to essentially cover all the molecular alterations. So there are chances where you're not able to cover the resistant mechanism that was generated from your prior treatments. So as you can see here on the graph on the right-hand side, NB003, which is the one that's highlighted in the red dashed box, you can see that it actually has good coverage, at least in preclinical testing, of all the known or well-documented GIST mutations, as opposed to some of the other drugs that's available. You can see all these boxes are green in color. So it covers, of course, the original mutations, including exon 9 and exon 11, but also the common secondary resistant mechanisms, including exon 13, 14, as well as exon 17 and 18. And they did present their preliminary data both at ESMO in 2023 as well as in ASCO in 2024. And we actually did also select that abstract to be presented and discussed at our LifeRaft group discussion last year. And during those 2 presentations, this drug already showed encouraging responses as well as disease control in patients with advanced GIST. So in this particular clinical trial, this is a phase 1 clinical trial where, of course, the main priority really is to identify some of the toxicities and side effects of the drugs, as well as to find the right dose to be tested in subsequent testing. And actually in 2024, the group presented the part 1 dose escalation, where there was a smaller number of patients with their compound and what they have established in terms of its efficacy. Now, for this particular presentation this year is an update of the same trial where there are more patients within the clinical trial now. And this is an amalgamation of both the part 1 dose escalation as well as the part 2 dose expansion of the study. And you can see that the total number of patients being discussed here is 158, which is quite sizable for a phase 1 trial on GIST. And more importantly, there's also discussion of the part 2 dose expansion group, where you can see here on the slide, the clinical trial is broken down into different cohorts, where each of the cohorts do contain patients with specific characteristics. You can see that in cohort 1, you have patients who have had more than or equal to 5 lines of prior treatment. So what we would say quite heavily pretreated, and essentially all the US FDA approved drugs for this situation would have been used in these patients before they're exposed to this NB003. And likewise, in the separate cohorts, in actual fact, we are separating the patients based on the treatment history. And hopefully with that separation, we're then able to identify where in terms of positioning is the best place to put NB003 in the treatment paradigm, depending on the efficacy results that we see from the patients within the study. The key objectives of the study is, as a phase 1 trial, to assess the safety and tolerability of the drug, as well as to find the recommended phase 2 dose. And in part 2, which is this bigger cohort, again, to assess the safety and tolerability, and as well as to explore the efficacy in the different disease cohorts based on their prior treatments. So this is a table showing the baseline characteristics of the patients that were recruited within this clinical trial. I think I would bring your focus to the right-hand side, which actually gives you the total number of patients. And you can see essentially that we have a large group of patients predominantly with KIT exon 11 mutations that accounts for 79.1% of the patients. There are also 16.5% or 26 patients were within the clinical trial actually had KIT exon 9 mutations, and some with other mutations as well. On the bottom here, you can see the number of lines of prior treatment. And what you can see here is most of the patients actually have had at least 2 or more lines of treatment, and actually about 35.4% or 56 patients have had more than or equal to 5 lines of prior treatment. And this is one of the more striking graphical presentations of the results of this particular trial, where on the left-hand side here, you can see the objective response rate of this particular compound in the entirety of the patient group. So patients who have had 1 or 2 lines of treatment, as well as patients who've had more than 5 lines of treatment, the overall average in terms of the objective response rate is 28.5%. Now, just a reminder, when we talk about objective response rate, we are very pragmatic, again, in terms of our definition. And a patient who is deemed to have response is when a patient, after being treated with the drug, has a shrinkage of their tumor in terms of size, with a size reduction of more than 30% from the baseline. So when we talk about objective response rate, we're really talking about these patients here on the right-hand side of the graph, which are showing more than a 30% shrinkage of their tumor. At the same time, though, I would also argue that patients who have some disease control or stabilization is already benefiting from the drug. So sometimes we also use another definition known as disease control rate, or DCR. And this really accounts for all the patients who are considered to be having stable disease, which is this area here, as well as having a good shrinkage of more than 30%. So the disease control rate of this particular drug in the entire patient cohort was up to about 78%. Now, if we then further break this down into the different cohorts based on the different lines of treatment, a number of lines of treatment that the patient have had, you can see that for patients who've had less prior treatment, so if this drug is used in the 3rd line setting, the objective response rate is up to 46.7%, whereas if the patient have had more than 5 lines of treatment, the objective response rate is only 12.5%. So I think what this really shows is the fact that this drug is potentially efficacious in a large group of patients. Having said that, patients who've had less prior treatment seem to benefit a bit more. The other take-home message I just want to make sure I bring home is the fact that although we look at these numbers and sometimes you might think, oh, an objective response rate of 12.5% seems a little low numerically, but if you look at the graph, there is a larger proportion of patients who didn't make the cut of defined as having an objective response, but certainly still benefiting with a shrinkage of the sizes of their tumors as their response to treatment. So it's very important for us to not only look at the numbers, but also look at the graphical representation of these waterfall plots to get a better understanding of the efficacy of the drug in our patient population. Now, another way of looking at how good a drug is working is looking at progression-free survival, whereby it's the definition of that is really the time it takes from starting the drug to a point where there is definite evidence of growth of the tumor, and essentially declaring the fact that the drug is no longer useful. And you can see here, looking at the various various progression-free survival or survival data based on the different cohorts, you can see that in actual fact, the objective response rate here for third-line treatment was 46.7%, fourth-line treatment was 42.9%, and then for fifth-line or beyond is 12.5%. This is essentially the numbers that were shown in the graph previously. If you look at the progression-free survival, again, patients who have had less prior treatments did spend more time on the drug, being able to benefit for a longer period of time. So 13.7 months or 13.8 months for patients who are being treated in the third or fourth line setting. But then when in the fifth line setting, numerically, it comes down quite a bit with only 4.3 months before the patient's disease really catches up and then starts growing beyond control. This is another representation of how the patients fared in terms of their tumor sizes and responses after being treated with NB003. And the different colors really indicates the different lines of treatment that the patients have had previously, really to impress upon the audience that patients are actually benefiting, again, across the board. And also down here, really looking at the different type of resistant mutations and mechanisms, and it does seem as though that NB003 is able to have a broad coverage of the various secondary mutation or resistant mechanisms that's commonly found in GIST patients. Now, in terms of safety, as well as adverse events, these data actually, or very similar data, have been reported in their prior reports last year, as well as in the year before. And what we do see is there are some side effects, including some blood parameter changes, as well as some anemia and some changes in the liver function. But I think by and large, most of these side effects were well controlled with some hold of the drug as well as possibly dose reduction. On the right-hand side, it shows these toxicities leading to dose reduction, and you can see a very small number of these actually required a reduction in the dose, and that sort of echoes the fact that it's a relatively safe drug to use. And certainly we're not seeing a lot of patients having to discontinue study based on side effect or toxicity profile as well. So this is still a phase 1 trial, and certainly with this promising data, there is a plan to do a global phase 3 clinical trial, which is a randomized trial looking at this compound NB003 versus regorafenib, our standard of care in the third line setting. And we look forward to seeing these results in upcoming conferences. But overall, at least based on this presentation, it does continue to show that NB003 has a manageable safety profile in this ongoing study. And they've also established that in subsequent analysis, the dose that they're going to use would be 15 milligrams twice a day. So after that abstract, I've selected 3 more abstracts to be presented. This is the second abstract, which is a poster that was presented during the poster session. And this is actually a real-world evidence study looking at the second-line treatment patterns and outcomes of patients with advanced GIST. And the study is based out of a multi-center collaboration from mainland China and presented by Dr. Zhang on behalf of all his co-authors. And essentially, this is a study where they involved a large number of what we call high volume cancer centers within mainland China, where they enrolled patients with advanced GISTs who have either progressed or have shown intolerance to first-line treatment. And for those patients, in actual fact, their data in terms of what treatment they got as the second-line treatment, their treatment outcome, their toxicity profile were all registered in a large database. Essentially, the primary endpoint really was to look at the progression-free survival, as well as secondary endpoints, including the safety and response rates, as well as overall survival based on their subsequent treatments. And what they have managed to pull together is a total of 99 patients involved in all of these different study sites between October 2022 and November 2024. And these patients within their clinical management were offered various types of second-line therapy. Including 49 of these 99 patients had ripretinib as a second-line therapy, 47 of them had sunitinib, and 3 of them had regorafenib. You can see the demographics on the left-hand side, again indicating the characteristics of the patients that were recruited into this study. And essentially at median follow-up of about 13 months, what they have found was in terms of the response rates of the patients, 22% of the patients treated with ripretinib had an objective response. And what that means is, again, going back to the definition of objective response, 22% of the patients who were treated with ripretinib was able to have a shrinkage of the tumor of more than or equal to at least 30% from their baseline. In patients who were treated with sunitinib, a smaller number, so 9% of these patients had an objective response. And out of the 3 patients that were treated with regorafenib, none of them actually had an objective response. They also looked at the median progression-free survival. And again, what they found is that patients treated with ripretinib had a 12.8-month progression-free survival, as opposed to patients who were treated with sunitinib at 11.1 months, and then regorafenib at 2.8 months. And just to also highlight here, I think is important at looking at the primary KIT mutations of the patients being treated in the different cohorts. Now, this is a real-world study, so essentially this is a retrospective look at the treatment patterns of these patients. And what you can see here is, again, the clinicians are really deciding on what particular best drug to use in the second-line setting based on the primary mutation that the GIST had in the initial diagnosis. We know that, for example, in patients who actually have KIT exon 11 mutation, when they actually do progress on imatinib, there's a good chance that they may have KIT exon 17 and 18 mutations, lesser chance of having KIT exon 11 and 13. And so therefore, what you can see is a larger proportion of these patients decided, or the clinicians decided to choose ripretinib as their drug because it has better coverage. Likewise, at the same time, if they actually had KIT exon 9 mutations in the initial diagnosis, we have shown in prior clinical trials that sunitinib may perform better than ripretinib in these patients, and therefore in the second-line setting, the clinicians decided to choose sunitinib as their second-line treatment. Now, really looking at the summation and the overall results, the investigators have determined that ripretinib showed better progression-free survival in patients who had primary KIT exon 11 mutations as opposed to sunitinib. And you can see here on the Kaplan-Meier curve on the left-hand side, you can see that specifically in patients who have KIT exon 11 mutations, the median progression-free survival was 12.8 months as opposed to sunitinib being 9.57 months. And in terms of safety profile of the different agents, again, this is very similar to what we see in clinical trials as well. The different drugs do have different safety profiles, but overall, in terms of the side effects and toxicities, it does seem as though a lesser number of patients had what we called grade 3 or 4. Which are more important side effects when they were treated with ripretinib as opposed to patients who were treated with sunitinib. So the third abstract I want to discuss is actually a interesting study coming out of of Oregon Health Science University, essentially from Dr. Michael Heinrich's group, and presented by one of his more junior colleagues, Dr. Julia Levy, which is a 15-year survivorship analysis in patients with metastatic gastrointestinal stromal tumors. And what this particular abstract was looking at are specifically patients who are able to essentially have a long survival, and their characteristics as to why they may be benefiting from treatment for such a long period of time. And essentially, the reason why they decided to look at this or do this analysis is typically when we look at oncology trials, we look at 5-year outcomes, and these are certainly well studied, but we don't really know what some of the factors are that are associated with longer term survival. And the identification of some of these predictors for longer term survival may help us inform our long-term management strategies for patients with metastatic GIST. So this is a retrospective chart review of their own cancer registry at their Oregon Health and Science University of essentially patients with GIST that were treated within this 20-year period between 2003 and 2023. And out of these patients, they essentially split this patient group into two different groups. One cohort are the patients who died before 15 years of follow-up, and those other group would be patients who survived for more than 15 years following the diagnosis of metastatic GIST. And you can see that out of this 20-year period, they were able to pull together a total of 111 patients, where 17.1% of these patients had a survival of more than or equal to 15 years, and the remainder actually had a survival which was shorter than this period. And looking at the main take-home messages, again, from this particular poster, on the left-hand side here first, it addresses the time to development of imatinib resistance by 15-year survival status. So what that really brings home is the fact that for the patients who are able to survive for a longer period of time, so the patients who actually had more than or equal to 15 years survival, it seemed as though these were the patients who actually had a very good control and a long duration of control whilst they were on imatinib. Whereas for the patients who actually had a short control with imatinib, ultimately they actually had a lesser chance of being a long-term survivor. On the right-hand side, it also shows the fact that for patients who are able to have a long survival, so again deemed to be a 15-year or more survivor, there's a higher chance that they've had a metastasectomy, which essentially means a surgical removal of any of these tumors that are shown to be resistant to treatment. You can see here it's 79% of the patients in the long-term survival group versus only 46% in the patients who were in the short-term survival group. And specifically, again, it's really doing these surgeries at an earlier time point before imatinib resistance, which again really is able to bring home this longer survival. So really what that takes home, or what that sort of shows, is the fact that number one, for patients who are treated with imatinib, if they benefit for a longer period of time, the chances are they will be able to survive for a longer period of time overall. And the other thing is, if you are planning to do a surgical resection of the recurrence, it would probably make sense to do it at an earlier stage and not wait until you move on to second line or third line treatment, because it seems as though if you're able to do it whilst the patient is still on the first line treatment, they are able to overall survive for a longer period as well. And this does make sense given the fact that as patients are being moved on to second or third line treatment, you are going to develop more and more different heterogeneity of resistance mechanisms, and they do become harder to treat. So if you're able to take out some of these tumors earlier on, then the chance of you having different resistant mechanisms may actually decrease. Now, the fourth and the final abstract I just want to discuss that was presented is actually a trials in progress poster. So unfortunately, we don't have the results of this trial yet, but I do want to bring home of the fact that there is this trial ongoing to the GIST community, and certainly for our patients as well as the clinicians who are involved in treating these patients, whether or not referral to one of these SARC sites looking at this particular trial may be useful for our patients. So the SARC-004 trial, SARC-044 trial is actually a phase 2 clinical trial of bezuclastinib in combination with sunitinib in patients with GIST who progressed on sunitinib. This was presented by Dr. Candace Haddox on behalf of the SARC investigators. You may be familiar with the drug bezuclastinib because in actual fact, bezuclastinib is the drug that's being combined together with sunitinib in the PEAK trial, and certainly we are eager to look forward to having the final or the results of the PEAK trial to be presented in upcoming conferences. But essentially, bezuclastinib is a drug that covers some of the resistant mutations that sunitinib is unable to cover. And the PEAK trial actually specifically is a trial for patients who progress on imatinib and then using sunitinib and bezuclastinib combined in the second line setting. The difference between the PEAK trial and the SARC-044 trial is the SARC-044 trial's targeted patients are patients who have had imatinib as well as sunitinib, and then upon resistance to sunitinib, then add on bezuclastinib. So it is slightly different in terms of the patient population. And the other thing that's different about the SARC-044 trial is it is a translational research trial where there is a lot of emphasis looking at the science behind the responses of the patients. And so therefore there are a lot more intensive, say, radiographical imaging, blood taking, as well as potentially biopsies. But really this all helps us understand a bit more in terms of the resistant mechanisms as well as the treatment duration or treatment outcomes of our patients depending on the biology. So what you can see here is the left-hand side showing the key eligibility in terms of the patients to be recruited. And again, patients must have exon 9 or 11 mutations and had prior progression on the treatment with sunitinib. Once they have gone through the screening process, they get started on bezuclastinib first for the first 14 days, and then subsequently to be added, sunitinib to be added again, and then continued as a combination. You can see here down at the bottom that at different time points, there'll be different blood draws, different imaging, and really for us trying to understand and tease out where or which of the components in terms of sunitinib or bezuclastinib really helps to control these resistant disease. Now, a group of patients within this particular trial, a subset of about 20 patients, will also be going through this particular PET-CT or biopsy cohort, where again, patients will be asked to do a PET-CT after the initial first cycle of treatment. And then in situations where there is a growing tumor, or in situations where there is good shrinkage of the tumor, or in situations where there are any other accessible tumors, these tumors will be biopsied. And hopefully we'll be able to then compare with the original specimens and then to be able to see what are some of the dynamic molecular changes that happen to patients after they're treated with this combination. And certainly this trial is ongoing. So as a trial in progress poster, the main emphasis is really try to bring the attention of the community to the fact that there is this trial open. And certainly for our patient community, if you do fit this particular criteria, do talk to your physicians to see whether or not a referral can be made to one of these sites to be able to contribute to this particular study. So with this, I just want to conclude by saying the fact that I think the theme of this year at ASCO for GIST really is us continuing to recognize the fact that GIST is a heterogeneous group of diseases. We are making strides to tackle the issue of treatment resistance. We have new drugs being studied, including, say, MB003. And potentially, we may even be able to bring this to an earlier line setting. And I think the SARC-044 study has actually quite clearly shown that a heavy translational research component hopefully will be able to improve our understanding of our group of diseases. And we've also seen data looking at some of the real-world evidence, which actually does provide additional insights into natural history of our group of diseases, as well as the associated treatment outcomes. So with this, I would like to end, and I'm very happy to answer any questions that you might have, and also just to highlight the fact that we will be having our next sarcoma masterclass to be held at our institution in September in Hong Kong. If you're able to travel to Hong Kong, do come and join us, and do let me know. Our website is here at cuhksarcoma.org. If you're unable to attend, not a problem. In actual fact, all our lectures will be recorded, and we would definitely then be putting it up to our website, and you'd be able to look through some of that material, which actually can be quite useful and helpful for the patient community as well. So thank you very much.
Oh, that's very exciting. Thanks for sharing about that masterclass. We'll definitely try to tune into that. Thank you for the overview of these highlights from ASCO. There were a number of different posters and presentations, but I think Dr. Loong really highlighted some good ones for today's webinar. So thank you for sharing. Okay, we got our first question. So with the phase 1 study you mentioned first, so that must be the Nube. You said PFS is 13.7 months. Does that mean the study has been going for 3.7 months at this point? So obviously PFS could be much longer. Do you understand the question? Yeah.
Okay, so I think this is the slide where we mentioned the progression-free survival. And in the third line setting, you can see, oops, sorry again. You can see it's 13.7 months. So I'm not quite sure in terms of the question.
Oh, she clarified the PFS was mentioned as 13.7 months. Does that mean the study has been going for 13.7 months? But I can answer that. No,
yes,
the study's been going
for more than 13.7 months.
Yeah.
Yeah. Okay.
Okay. Somebody wants to know if there's anything on the SDH front to share.
Not particular. I mean, I think at this year's ASCO, I did not see much in terms of the SDH space. Last year, actually, we did have quite a bit of information. We had the overambatinib trial that was being presented. But this year, I did not see much in the SDH space. Having said that, each year there are many conferences, and in a couple of months we have ESMO coming up in Europe, and then also CTOS coming up in November. So maybe we'll be able to catch some of that information then. But at least based on what I saw, there were not much SDH presentations at this year's ASCO.
Okay. Actually, let's just stick with the Nube. This focus seemed to be on the KIT mutant mutations. Was PDGFRA ever explored, and will that be considered in the phase 3 trial?
Yes. So I believe, to begin with, we know that actually the drug should have activity in PDGFRA, certainly based in the preclinical studies, as well as in the earlier phase 1 dose escalation part. There were patients with PDGFR alpha. At the same time, though, if you look at this particular slide here on the different cohorts, I would say that almost the majority of the patients, if not all the patients, probably did not actually have PDGFR alpha, because if you look at the different cohorts based on the prior lines of treatment, they were not going down the PDGFR alpha route. And if you look at the characteristics here, A small number of patients had other KIT mutations, but there were no patients included in this group who actually had PDGFR alpha. So I'm not sure whether there's a plan by the drug company to investigate that particular space. I would probably think their emphasis and priority is in the KIT space, but at the same time, later on, we may be able to get some retrospective review of patients who may be exposed to this drug, or there may be a potential use of, say, expanded access use or compassionate use. But my understanding is there is no clear path right now of this drug for PDGFR alpha.
And do you have a sense of when the phase 3 trial may be initiated?
I think the plan is that they are putting things together and trying to start it within the next year or so. I'm not an investigator in the trial, so unfortunately, I don't know, in terms of the timeline. But at least based on Dr. Chi's presentation, that is the definite plan. Again, to put it head to head against regorafenib.
Okay, great. Do we know what the resistance mechanism is for progression after secondary mutations treatments on second or third line, especially if biopsy of progressed tumor does not show any new mutations in KIT beyond the secondary mutations?
Yeah, so I think that's a very interesting space where I think we're starting to explore. So a lot of emphasis has been put on the first resistance, and we sort of now have a good feel of what the first resistance is, because it does seem to follow particular patterns. But after a second line treatment, so I guess the variety of resistant pathways can be quite large. As rightly pointed out in the question, it could be a KIT dominant resistant mechanism where potentially if you also target KIT in another way, you're able to control. But that's also a situation where you may have non-KIT driven alterations. And I think we're still collecting this data based on our experiences of saying using liquid biopsy and really trying to get a good landscape and overview of what some of these potential resistant mechanisms are. I would say there's no clear-cut consensus as to what the next approach is. It's very patient determinant, very individualized. And many a times we may consider, again, doing a biopsy, either a liquid biopsy or a tissue biopsy. And in situations where we do see resistant mechanisms which potentially can be targetable by other drugs, we may consider off-label use of some of these drugs in combination with the KIT inhibitor. But what we really need as a community is to pull all this data together, because I believe each of us who are involved in the treatment of GIST patients may have one or two or a handful of patients who have gone through this route, but we have not had a good database to be able to pull all this experience together. And I guess this goes back to Sarah and her colleagues, whether or not the Life Raft group can help us, bring all this data together. I'm thinking of ASCO 2026 poster. So that's something that I think we can do for the community.
Thank you for the plug. We'd be happy to do that and encourage as many patients to share their information so we can collect that and not have it sit in silos, but to be able to share that with the public. It's very meaningful. So thanks for recognizing that. And I think even the 15-year poster that you shared at OHSU was very insightful in terms of looking at that real world data over time. Do you think that, I think it's very clear that a lot of patients were able to stay on imatinib, and I think that helped with the survival. In terms of research going forward, how we can get ahead of the resistance at an earlier stage. I know we're always looking for a cure, but like some of these other therapies that you highlighted are at later stages. What do we do about earlier stages to catch it before it gets bad? Dr. Loong, are you there?
Yeah, I think that taking it with a grain of salt, this is a retrospective look, so there are inherent biases. Can you hear me? Yeah, but at the same time, I think this really points out the fact that yes, there is very natural for us to jump to second line treatment, third line treatment, but we should take a step back and think about the other modalities of treatment, including, say, surgery, including, say, potential interventional radiology, including radiofrequency ablation, etc. Um, to be honest, that's actually a concept that we are also using in other cancers. So in lung cancer, which I also treat, again, in our population, we have a lot of EGFR positive lung cancer where there are 3, 4 lines of targeted therapies. Again, it's natural for us to jump to the second or third line, but then we also realize that if we're able to address it with other means, we're able to extend the period of using the original targeted therapy. And overall, it does impact survival for patients. So I think the same concept can be applied to GIST.
Yeah.
And one of the issues really has to do with how, with your surgical team and your interventional radiology team, and whether the patients who are being seen by the oncologist when starting on would then come in again and say, oh, well, there's actually disease progression. I will help you take out the metastasis and then subsequently come back and continue the treatment. I think this dialogue, this communication will actually help patients to be able to be engaged by different disciplines. And with this particular framework in place, I'm pretty sure that the outcomes overall would be better. So I think that poster really brings home the fact that it has to be multidisciplinary in terms of treatment of GIST patients, and not just in the very beginning, but throughout the patient journey to make sure
Yeah.
that they get the best opportunity of treatments at the different stages of their disease.
Okay, I think I got the gist of what you said. We're going to make this the last question because there's a bit of a connectivity issue. Did any presentations discuss ULK inhibitors or the combination of those with KIT inhibitors?
Not that I saw, not that I came across. So, I could definitely take a look back at all the abstracts again to see whether or not this was on my radar when I looked through the abstracts.
Okay. Thank you, everybody, for spending this time together, and for Dr. Loong for also putting this presentation together and presenting these updates. Always very insightful. And if anybody has any follow-up questions, I think you know how to reach us. And thank you for the time, and have a wonderful evening, morning, wherever you are. Take care, everyone.